Assalamu alaikum wa rahmatullah. Good evening, our distinguished speakers, our colleagues, healthcare professionals, researchers, and all the participants joining us today. On the behalf of the Tropical Diseases Teaching Hospital Academic Club, it's my great pleasure to welcome you all on board for today's session. It's covering Ebola virus disease, the current outbreak updates, virology, epidemiology, and the outbreak response. Ebola remains one of the world's most serious viral hemorrhagic diseases, outbreak posing significant challenges to health systems, particularly in limited resources. The current outbreak in 2026, it's basically continued to be, it continued to demand urgent global attention. According to the latest updates, excuse me, the outbreak has primarily affected the Democratic Republic of Congo, with cross-border transmission into Uganda. As we're speaking in June 2026, more than 1,200 confirmed cases and over 320 deaths have been reported in the DRC. 20 confirmed cases, including 2 deaths, has been recorded in Uganda. Health authorities continue to strengthen surveillance, contact tracing, lab testing, infection prevention and control, and community engagement to contain the outbreak. As we're talking about Sudan, it's one case, one border. That's all it takes. This evening, we are privileged to learn from 2 distinguished experts whose experience spans virology, field epidemiology, and emergency response outbreak. We have Dr. Muntasir, who kindly joined from the Federal Ministry of Health to take us about the updates in Sudan and the emergency response. Please welcome our 2 speakers for today. Dr. Michael Kidd. He is a consultant clinical scientist in virology at the UK Health Security Agency Regional Virology Lab in Birmingham, United Kingdom. Dr. Kidd will bring extensive expertise in diagnostic virology and emerging infectious disease. My second speaker would be Dr. Muntasir Mohammed. He's a director of Sudan Field Epidemiology Training Program and the Director General for Health Emergencies and Epidemics Control at the Federal Ministry of Health, Sudan. His leadership in outbreak preparedness and emergency response has made significant contributions to the public health across the country. We're honored to have you both with us and would like you to share your knowledge, insights on the evolving Ebola situation, the science behind the virus, the critical strategies needed to strengthen the response. Without further delay, it's my pleasure to invite our first speaker, Dr. Mike Kidd. Please, the floor is yours.
Many thanks, Salah. And I'm very pleased to accept the nomination for our honorary Sudanese member. Thank you very much. That's very kind of you all. I work for the UKHSA Regional Health Laboratory in Birmingham. My expertise is also gained from being a member of the UK Advisory Committee for Dangerous Pathogens for about 10 years. And this is a UK organisation that advises government on the risks of dangerous pathogens, of which Ebola is obviously one. And I happened to be on that committee when we were considering all the evidence of infectivity, clinical prognostic factors associated with the very extensive outbreak in West Africa between 2014 and 2016. And I learned a lot from reading the background and helping to advise on the safe method of managing patients and transport of samples and laboratory construction. We also occasionally get involved in our local laboratory with assessing patients who've flown back from areas where there are current Ebola virus outbreaks. In fact, I had a call this morning, which thankfully turned out to be a case of malaria. But it just shows that everybody's on their toes and anxious to make things as safe as possible, even though we will probably get small, if even one case from this particular area. Anyway, thank you very much for inviting me to talk. That's enough about me. So I'll go on and with my talk about Ebola. So in context, Ebola is only one of a group of viral hemorrhagic fevers that cause a lot of concern in the world. Really, these all cause severe and life-threatening viral diseases. I mentioned ACDP. They have, in common with the European and the American public health authorities, set different hazard groups, and Ebola is one of the, it's in the top group 4. VHFs are found all across the world, in Africa, South America, and the Middle East, some in Eastern Europe, and some in Spain, in fact, at the moment. And we usually encounter Ebola, Marburg, which is another filovirus, Crimean Congo hemorrhagic fever, which is the one that's in Spain at the moment, and Lassa fever. You'll be all familiar with these, I'm sure. And they're a particular public health importance because they tend to have a high case fatality rate if they're not diagnosed early. They can spread readily in a hospital setting. They're difficult to recognize, either because they have an insidious onset or their features match with other common infections that may be occurring in the same region. And there's no immediate effective treatment, except supportive, perhaps. And just on the UK, the environmental conditions do not support the natural reservoirs or vectors of any of these viruses. But with current climate change going on at the moment, it may be possible for ticks that carry Crimean Congo hemorrhagic fever to become established, and there are surveillance systems in place to try and detect that. So the agents of VHF, there's a broad list there. On the left, there's the arenaviruses, which really are mostly associated with Africa and South America, the New World. And then right at the top right, the filoviruses, Ebola and Marburg. Bunyaviruses and flaviviruses, we won't say much more about those. We really want to concentrate on filoviruses. So the most famous members of this group are Ebola and Marburg, which is a related but genetically distinct filovirus. They're about 80 nanometers in length, and on the right of the screen, you can see what they look like under an electron microscope. They've got this curious morphology. They look like a tangled up piece of string. And if you untangled that and stretched it out, if that were possible, it would be about 80 nanometers in length, which makes them about an average size for a virus, but a very unusual shape and instantly recognizable. It's, for those of you with the technical bent, it's a single-stranded RNA genome, negative sense, which means it's got to do a bit of work to transcribe its genome into messenger RNA to make proteins, and that makes it susceptible to antiviral drugs at some stage or another. So the main group is the ortho Ebola virus, and this contains the 4 main ones, 4 main members of the group. Each of these have got up to about 40% difference in nucleotide sequence. So there's a lot. That's quite a lot of difference between all of these, and gives rise to some of the ineffectiveness of antiviral agents and vaccines that have been previously successfully used against a different member that starts causing epidemics and outbreaks in a different country. So the first is Ebola virus, which, as you might guess, causes Ebola virus disease, EVD, and I think this is the virus that used to be called Zaire Ebola virus. It was renamed. The next one is Thai forest virus, which is an unusual one. The third one is Sudan virus, abbreviated to SUDV, and this was detected in South Sudan in a couple of outbreaks at one stage. And then the one that is most on the map at the moment is the Bundibugyo virus. And I had to work quite hard to understand how to pronounce that. It doesn't trip off the tongue necessarily, but I believe I'm close to pronouncing it correctly. There's only one Marburg strain identified. It's a very serious disease, but again, we won't consider that any further at the moment. So what's thought to be the reservoirs of filoviruses? Well, there's been a lot of behind the scenes animal trapping missions, particularly in the Central African rainforests, and a number of bat species have been under suspicion, and some of them are found to be naturally infected with Ebola of one kind or another. So there's a hammer-headed bat, which is the one on the top of the right-hand side. You can see why it's called. It's an unfortunate head shape. And then the singing bat, which I believe is that one underneath it with a red background. And then a little collared bat, which I couldn't find a picture of, I'm afraid. But apart from the hammer-headed bat, I think most bats look around the same. So the infection in these bats is asymptomatic, and they excrete virus in saliva, urine, and feces. And the virus is infectious. And it's been observed that, particularly in Central Africa, the human Ebola outbreaks follow epizootic outbreaks. And you may wonder, well, how can it be epizootic if these bats are asymptomatic? Well, it's more that primates, such as chimpanzees, will feed on fruit that's contaminated with saliva of bats, fruit bats, and acquire the infection that way. So the bats have been eating the same fruit in essence, or they can become infected through deposition of urine and feces on the ground. There may be some possible direct consumption of dead bats, but that's a very difficult thing to. I don't think that's actually been observed. It's quite easy to, and it parallels with other dangerous viruses like Nipah, which can, in other areas of Southeast Asia, can be transferred from bats, asymptomatically infected bats, to humans just by eating the same fruit that the bats have been also feeding on. So away from the reservoirs, the evidence from outbreaks, transmission, human to human, the evidence is strongly suggestive that it's direct patient contact, and that's via mucous membranes or broken skin, with blood or body fluids, or material that's been used to wash infected individuals. It's also possible to be infected by indirect contact via contaminated environments, and that would be, for example, in a hospital, if blood spillages are not cleaned up properly, or any other, for example, saliva or vomit is not cleaned up properly, then it's possible to be infected indirectly from them. And importantly, from an infection control perspective, and we'll see this a bit later, patients only become infectious at the onset of symptoms. So there's no asymptomatic transmission that occurs. Patients are almost always unwell before they become infectious. And finally, there's no circumstantial or epidemiological evidence of any aerosol transmission. So there's no evidence of the respiratory route of transmission about aerosol generation. And it's instructive to look at the history of Ebola virus outbreaks in Africa, because much has been learned about them and how they may be controlled. So I think there's a list on the left-hand side, starting with Zaire. There was 8 large outbreaks in the mid-90s to early 2000s. The number of cases that were identified was not that many, but of course, can we be sure that they were all that they were all identified properly. That had a very high mortality rate of almost 60 to 90%. I mentioned South Sudan, 3 known epidemics, 50% case fatality. Côte d'Ivoire, the first time that Thai forest virus TAFV was identified. This was as a result of many primate deaths, chimpanzees and one human case who was involved in post-mortem examination of some of the primates and acquired virus and was rapidly transported to hospital with supportive care and in fact survived. In Uganda, there's been other outbreaks since 2000, and interestingly, one of the outbreaks was caused by Bundibugyo virus, BDBV is its abbreviation. Marburg, that rare one I mentioned before, and then South Sudan, and then Sudan virus, SUDV. Reston is an unusual filovirus. It's not really pathogenic for humans, which is why it's unusual and has been under a lot of interest with respect to vaccine development. This is maintained in pigs as the animal reservoir, domesticated pigs, and humans are infected as a result of overspill infection from them. West Africa. Oh, hello?
Yes, we can hear you clearly.
Sorry, I got a message on my screen. I think it was something else terminating
Right.
terminating on my computer. Sorry. Okay. Good, you can hear us.
The-
Yeah, so let's move to West Africa, 2014. This was the largest ever recorded Ebola epidemic. It was a new variant of the Zaire Ebola virus and had a case fatality rate of approximately 70%. More recently, in DRC in 2018, another variant of the Zaire Ebola virus, not quite as big an outbreak, but 70 cases and 42 deaths, so still got a high case fatality rate. And in Uganda, 2022 to 23, Sudan Ebola virus, 167 cases with 77 deaths. So the West African outbreak had widespread transmission. Guinea, Liberia, Sierra Leone, the entire country of each of those was affected. And of course the point was made early on in the recognition of the epidemic that actually these country borders are and often not recognized by the inhabitants. These were imposed on them a long time ago, and they just recognize they're all part of the same country and just carried on with their social relationships and trading routes. And so it's very difficult under those circumstances to try and restrict movement across the borders. Anyway, it led to observationally the entire country, all of those 3 countries being affected. And there were exported cases to Nigeria, Senegal, Mali, Spain, and the United States, and one case in the United Kingdom. Accumulated cases, you can see by the y-axis on the left-hand side, huge numbers. The blue line is Guinea, the red line is Liberia, total cases, and the green is Sierra Leone. So, which Sierra Leone suffered 14,000 cases, and the whole, all of that adds up to about 28,000 individual cases. And this is the incidence of Ebola cases. So the blue areas of West Africa, although the shaded blue areas are the prevalence. So that's the accumulating number of cases, but the orange and red dots is the incidence. So where all the new cases are arising in both the past 7 days. This was a particular snapshot about halfway through the epidemic in April 2015, and you can see there's still quite a lot of active transmission going on. And then the geographical distribution of Ebola virus. Again, very large circles showing how many cases. This was taken at the snapshot at the end of the outbreak. I think after it had just been declared disease, these areas have become disease free. So there'd been no confirmed cases or red dots in the past 7 days, or in the past 21 days. So this was all an accumulated number of cases once the epidemic had been brought under control. So what's the pathogenesis of Ebola severe disease? It's actually really complicated. It's not just a matter of the virus coursing through the body and infecting certain organs and cause an overwhelming infection. It has a number of side effects. So first of all, the coagulopathy. There's profound dysregulation of clotting system. You get overexpression of tissue factor. The fibrinolytic system, which is meant to control the controlled removal of clots in a normal healing process, is again dysregulated, and there's a reduction in protein C. A mysterious effect is that all lymphocytes start to undergo apoptosis. So for some reason, they're induced their own self-killing mechanisms. It's not that the virus is infecting them and lysing them through its own replication. It doesn't, in fact, doesn't infect lymphocytes. They're not permissive for Ebola virus. But in some way, lymphocytes just go through a high level apoptosis. So really, once the lymphocytes have gone, there's very little left to manage an appropriate immune response to try and clear the virus. And then there's other dysregulated cytokines, too much interferon alpha, an underproduction of interferon beta, and a lot of this has parallels with bacterial septic shock. And this is a summary of some noting from from observational studies in the West African outbreak. The incubation period is about 3 to 21 days, and that's about the same as the estimated for the Bundibugyo virus. Average of 11 days for onset of symptoms. Again, you're infectious only when symptoms appear, which is fortuitous for infection control. It's an abrupt onset, headache, myalgia, some abdominal pain, diarrhea and vomiting in the severe cases, fever up to 38, sore throat, hepatic-like lesions on the mouth and pharynx, and some discoloration, a non-productive cough, lymphadenopathy, some eyes, some injection, conjunctival injection, and 50% of patients get a maculopapular rash on their trunk. In week 2, things progress more seriously, and patients will develop prostration and stupor, blood pressure will fall, hemorrhages will occur, the injection will get worse, the rash will turn into petechial form, and hemorrhages will start from the gums and from any venipuncture sites that are being used for support, clinical support, and really gross bleeding from moribund patients from orifices. And in this state, the patient will be shedding large amounts of virus from bleeding sites, vomit, and loose stools. And there have been some observations of prognostic factors for the onset of for the progression to serious illness. So if these factors, so if you're over 40 years of age, if you develop diarrhea, obviously hemorrhage is a bad sign, difficulty in breathing, confusion, and then where it's possible to get diagnostic testing done and viral load can be measured, if your Ebola virus load is greater than 1 million copies per mil of blood, that's a bad prognostic indicator. And in West Africa, most individuals who did die were dying at an average of day 4 after admission to hospital. So they just really weren't able to be saved. But if patients do survive, they tend to improve by day 7 to day 11 of illness. So once they've made it that far, they're very likely to survive. Then, of course, there's a lot of those symptoms, as you will note, will overlap with the symptoms and signs of malaria or the other types of VHF. So if a patient has been excluded from, or they're thought to have malaria, they may even have a positive malaria film. The patient should always be reassessed if they're really not improving on either treatment or empirical antimalarials, and they start to develop the following signs. So obviously nosebleed and hemorrhage, sudden rise in AST levels, platelets, clinical shock, and then O2 requirements increasing drastically in the absence of another diagnosis. And then a rather strange phenomenon, which has interestingly reared its head in some analysis of the recent outbreaks in Uganda, is that some individual patients who were reported to have long sequelae, they're survivors of Ebola. They recovered, but they had a very long recovery time. And this was complicated by fatigue, arthralgia, ocular complications. And so when you're thinking about the scale of the West African outbreak, it means proportionally more of these complications should appear. And it's been noted and detected, virus has been detected in several bodily fluids, particularly semen. And I think the maximum so far is nearly 6 months, more than 6 months after the original disease onset. And documented sexual transmission has also happened in other outbreaks. There's apparent persistence of virus in other immunoprivileged sites, such as the eye or the central nervous system. So this may be a mechanism of transmission. Once an epidemic has burned out or been controlled in a country, it may be that there's still a risk of sparking other outbreaks by the persistence of virus in individuals. And there's two examples of this. There's just to cases in point. A US healthcare worker survived Ebola, of course, was airlifted back. They developed ocular complications and the eye was sampled and infectious virus was isolated from eye fluid, and that was highly transmissible, could easily infect someone else. Unfortunately, the healthcare worker temporarily lost his sight, but did get it back, recovered it fully without apparently any untoward further effects. And then the UK healthcare worker who also survived Ebola, about 10 months after she was discharged, represented with sudden onset of meningoencephalitis. And she was transported back down the country to the HCID unit at Royal Free Hospital, and virus was detected in CSF and blood. The level of virus was higher in CSF than in blood, and it was infectious after some isolation experiments were done under high containment conditions in elsewhere in London. And so, yeah, I mentioned similar cases have been detected in Uganda after the 2022 to 23 epidemic. And so there is a potential threat to other countries if Ebola survivors travel and the illness isn't recognized as a recurrence. So again, what did we learn from the West African outbreaks? Well, a number of therapies were tried out, and obviously it's very difficult to do this. You have to, even though you have a compound which you think will work or a vaccine which will work, it has to be done in a controlled trial, and a number of helpful adjustments were made so that these could happen in real time and yet still be ethically used. So there were three drugs: brincidofovir, which is a prodrug of cidofovir, and that drug's normally used to treat herpes. Well, it was normally used to treat herpes virus infections. Why it was working against an RNA virus, who knows? But that did have some beneficial effects. Unfortunately, I think it's not in production anymore. And then favipiravir, that's made by a Japanese company, and for a while looked like a bit of a wonder drug. It was active against influenza and a number of other RNA viruses, and so it was trialed in various settings in the West African outbreak, and was found to be partially beneficial as well. And then a different strategy was to administer these small interfering RNAs. So basically, they just bind to the virus genome and get in the way of the polymerase, which is trying to replicate the virus. But as you can imagine, they have to be quite sequence specific to bind tightly, and they have to probably be made specifically for all of the other different types of virus. You couldn't just use one and hope it would work for them all. Passive vaccination using convalescent plasma. That's often a good way of getting preformed antibodies into patients. And then there was a transgenic human monoclonal called ZMapp, which was touted as something very useful, and it was given to a number of patients in a trial, and it did seem to improve things. Then there was active vaccination. Two of the main vaccines were firstly were chimpanzee-derived adenovirus vector, in which had been inserted an Ebola virus gene. So that would prime if you were vaccinated with that, it would prime you against that particular Ebola virus. Can't remember which gene it was now. And then the second one was a vesicular stomatitis virus, a recombinant. Is now still in production, Avibo, and in fact is still approved for use in some Ebola virus in the Zaire strain outbreaks. It's a different attenuated virus. Again, one of its genes has been replaced by an Ebola virus gene, and that showed good utility in ring vaccination strategies in the West African outbreak. So Bundibugyo. So what's different? Well, first of all, brincidofovir is not available. I think favipiravir is not available either. And then, for the reasons I just alluded to, the small interfering RNAs are unlikely to be effective for a different virus. Passive vaccination. Well, yes, you could still use convalescent plasma derived from recovered survivors. Possibly useful, but then you've got to go through quite a lot of technical. You've got to make sure there's no virus in there, or it's been inactivated, and to prepare that to pharmaceutical standards, GMP standards, is going to be very difficult. ZMapp was ineffective, and so that's not approved for BDBV. The active vaccination, the two at the bottom, again, both of these are not going to be effective against Bundibugyo virus, and so they're similarly not approved by the World Health Organization. It wouldn't be ethical to use them. So what is available if we can't use any of that? Well, antiviral chemotherapy, remdesivir, intravenous remdesivir is an intravenous drug and has a wide activity against single-stranded RNA viruses. So this is something that some of you will remember has been in and out of the NICE guidelines for treating SARS-CoV-2 infections, COVID. It's made its way back in now because it does seem to have some effect. It also has been shown to be useful against other RNA viruses such as polio. And in one case, use of remdesivir probably cleared a chronic poliovirus infection in an immunocompromised patient. So this is now probably going to undergo trials in DRC against this virus. So there is a prodrug of remdesivir. The disadvantage of remdesivir is intravenous, so it could be used for hospitalizations, but there is now a prodrug, an oral prodrug of that. And so that's been prioritized as possible post-exposure prophylaxis for outbreak control. Now, both of these could be used in combination therapy with some of the passive vaccination candidates, such as convalescent plasma. Again, you've got the problems of how you're going to purify that and whether you lose any effectiveness if you do that. There's another two monoclonal antibodies, MBP134, which has two monoclonal antibodies in it. It was derived from virus, the virus that was involved in West Africa, but seems to work against Bundibugyo virus, surprisingly. Then maftivimab, that's similar. I think it's the same company that made the ZMAP on the previous page. They decided to combine three monoclonals, but one of them has been identified on its own, particularly active against Bundibugyo virus. So they're now trying to produce that as a single monoclonal antibody for therapeutic use. And then active vaccination, as you might imagine, there's some more. Two of the most promising candidates are, again, the recombinant fascicular stomatitis virus against Bundibugyo, developed by the International Authority, is it AIDS Vaccine Initiative, I think, and the chimpanzee adenovirus against Bundibugyo, which is developed by Oxford and Serum Institute of India. So it looks like there are going to be some things available. There are going to be some trials going on. And the WHO has a page. You can read more about this. You can download that brochure on the left-hand side, which just describes how the coordination is. They've set out lots of principles. DRC government, Ugandan government, and then I think a number of Pan-African organizations are also involved in this. And so on the face of it, it sounds promising that there are drugs and vaccines to be able to try to bring the virus under control. So this is my final slide. I just wanted to make the point that despite all of the vaccines and antiviral treatments that were used in the West African outbreak, it really was infection control that worked. Really, just as we know, the aim is to reduce numbers of secondary cases. And there's a list of 7 principles here, which it's easy to write these things down, but when you think about there are differences between West Africa and DRC, particularly it's very, very remote in DRC. So, how are you going to rapidly identify new clinical cases? It's going to be quite difficult. And then rapid transfer to hospital. Well, you've got to build these hospitals. Where are you going to build them? How are you going to get the transport through? Because a number of places where outbreaks may be occurring are inaccessible by road. Local diagnostic facilities. It's possible there are good PCR assays now that the virus has been recognized. But again, you've got to build these laboratories, probably next to the hospitals. And then you've still got to organize for samples to be transported to that laboratory, even from outlying areas where outbreaks are occurring. Vigorous contact tracing is a given, but that's going to prove this extremely difficult because of the terrain. There's armed conflict going on in the country. People don't necessarily welcome the news that they've been in contact with somebody who's had Ebola virus. And I remember reading that in West Africa, a lot of intrinsic resistance to interference in what was in normal life. And we've seen this in DRC now with medical facilities being burned and attacked. And it shouldn't be forgotten that in West Africa, several healthcare workers were killed by individuals in communities who did not relish their interference, and particularly in and around the burial practices, which were identified quite early on as being probably responsible for the huge increase in cases that occurred. Tens of individuals being infected through one event. And there was a huge effort went in from the WHO to establish these burial practices, but really a long piece of work to community to engage with communities and build up trust in with with healthcare workers that weren't necessarily from that particular area. And so if it was hard work in West Africa, I think it's going to be even more hard work in DRC. So yes, a lot of intensive community work needs to be done around cultural beliefs if it's possible to stop the large number of cases that can emanate from burial practices. And then we could probably think about the antiviral drugs and vaccines at some later stage. So I think I'll stop there. If that's okay.
Thank you so much for sharing your experience and insights about the Ebola virus. And obviously, there's nothing much to be done in terms of vaccination and active management like antiviral therapies. It mainly focuses on community engagement, the rapid identification, and most importantly, infection prevention and control. Thank you so much for sharing these valuable informations with us. We have few questions. Like usually we do take all the questions at the end of the session, but if you're busy or feeling too hot, uh, we can
No.
we can start asking questions straight away. Otherwise, if you kindly wait till the end of the session.
Okay, I'm happy either way.
That's wonderful. Then we'll wait till the end of the session after the next speaker. Thank you so much. Okay, again, allow me to briefly note that Ebola virus is severe. It's usually fatal. It's transmitted by direct contact. And as we know, with the internally and externally displaced people, border control can be difficult, meaning we are expecting an outbreak in Sudan. It does require a very rapid detection, isolation, contact tracing, strong infection prevention control measures. In Sudan, the response efforts are taking place despite major health system challenges, including the conflict-related damages to the healthcare facilities, affecting the healthcare personnel, and of course, the limited access to some of the medications, as well as the disrupted surveillance and referral systems, the limited lab capacities, and restricted access to the affected communities given the ongoing conflict. But to know more about what we're doing right now, allow me to present our next speaker, Dr. Muntasir Elnoor. He's the director of the Sudan Field Epidemiology Training Program and the Director General of the Health Emergencies and Epidemics Control at the Federal Ministry of Health. Dr. Muntasir has played an important role in strengthening the capacity for disease surveillance, outbreak preparedness, and emergency response. His leadership and contribution significantly advanced the field epidemiology, building a public health workforce capacity, and coordinating responses to major health emergencies across Sudan. Today, we face challenges we have to do in response to the current Ebola virus emergency. Dr. Muntasir, please, we can't wait for you to share your valuable insights into Sudan preparedness, response strategies, operation challenges, and the lesson learned from managing previously similar public health emergencies and inspired by the local or neighboring countries' experience. Dr. Muntasir, thank you so much for joining us today, and the floor is yours.
Thank you again, Dr. Zelan, and thanks to my first speaker, Dr. Mike, for this comprehensive information presentation. He relieved me from several slides. So I will start from, is it clear for you?
Yes, we can see your screen and we hear you clearly. Please.
Type, thank you very much. Type, the first I want to start from the definition of the acute viral hemorrhagic fever. As mentioned by Dr. Mike, it's different strains and different groups of viral hemorrhagic fevers that can give this a little bit similarity in the clinical features. Although it's different as per our experience here in the country with Ebola, dengue fever, yellow fever, Rift Valley fever, chikungunya, Crimean Congo hemorrhagic fevers. Most of those has some clinical features that call for each one, like periorbital edema. You will find it in the dengue fever, and also like the jaundice and epigastric pain and epigastric also hemorrhage. Is it like vomitus and also diarrhea with bleeding. You'll find it in yellow fever, Rift Valley fever with different clinical features. So all of these are here in the country, and particularly at this moment we are facing current seasonal outbreak and endemicity of dengue fever all through the country. So this is one of the challenges that we are facing when we put case definition without saying operational case definition for now. For example, now is Ebola virus disease. And actually, some of the reports of suspected cases without any link to any case outside the country were reported from different sides of the country and has been excluded by the diagnosis. طيب, this is the first what I can say about the hemorrhagic fevers in general in the country. And as mentioned, also for the clinical features, the clinical diagnosis with symptoms is very difficult, differential diagnosis. That what we learned from West Africa outbreak, delay in detection resulting in difficulties in containments and prolonged period of response within the country and outside the country. And this is very clear in West Africa because the first symptoms linked to December 2013 and first diagnosed linked to late March 2014, almost 4 months plus without diagnosis and or with some diagnoses that not linked to the disease itself, like cholera, like other diseases. So this is a challenge. And this challenge is unfortunately, although it has to be lesson for all the countries and also for all of us, we are now repeating it globally with Kundubugi Bugio outbreak in DRC and Uganda, because the first reported cases were more than 200 in Ituri County in DRC, and that means we fail to detect early the outbreak. This definitely is leading to prolongation of the period of the outbreak within the DRC and outside the DRC, as reported from Uganda, which although it contained the cases and only 19 cases reported till 10 days, but unfortunately 21st they report the 20th case. So we are still suffering, and we think, as mentioned by Zalal, and also all of us know, that disease has no border. And now we are observing it in cholera outbreak that hit the southern part, and we were free since January, 11 January 2026, but unfortunately we started to report on mid of May from West Kordofan cases linked to South Sudan. So the patient history, as mentioned also by Mike, I will not go further. Contact with dead, sick animal, contact with suspected, probable, or confirmed Ebola disease patients. This leads us to suspect a case of Ebola. As per the history of Ebola virus disease in Sudan, and I want to say it is Ebola virus disease with strains, including Sudan as one of the strain. Also, Zaire is one, and Montebugu is one, and Thai forest also is another one. So these are strains, because we are also have seen it in the dengue fever. We are not saying serogroup 1, serogroup 2, serogroup 3, serogroup 4, although they are different. And as mentioned by Mike, looks like they are different diseases, but it is the name of the disease itself is dengue fever. Dengue fever disease and Ebola virus disease. So I prefer for the globe and for the scientists to not to go more than that and politicize the disease, as mentioned in the Uganda in 2025 as Sudan virus disease. Although historically, the report was in Southern Sudan, it used to be part of Sudan, but if we want to name it, it's better to name it as Southern Sudan disease. Although we don't like this, and I was against naming and shaming MERS-CoV linked to the Middle East by geographical area and not as a disease itself. So go further that Sudan reported 3 outbreaks in the southern part of the country, 1976, 1979, and 2004, and all the case fatality rate were between 40 and 65%. And this is the areas, West Equatoria State, that reported these recurrent outbreaks during the 3 period of the years. You see it even the period is long, significant long, at least between 1979 and 2004. Until now, no any other reported outbreak in ex-Sudan and now in South Sudan as a new country. Transmission of the also Ebola virus diseases. We know the reservoir, the fruit bats. We have epizootics in animals like gorillas and other animals. Then introduction to human population. And when we said there we have an outbreak, when one confirmed case reported, and then we have, unfortunately, like secondary human transmission from this. That means sustained human transmission. Unfortunately, the first reported index cases all the time, we observe it, them in the health cadre when they are not following the infection prevention and control measures and not expecting the outbreak or suspected case of Ebola. The current Ebola virus disease distribution, as mentioned here, this is a map shared by WHO up to 21st of June 2026. We will find that it is almost in the Aituri County and now moving to the nearby border county in DRC, in addition to also Uganda, with sporadic cases up to now reported around 20 cases with more than 1,000 cases reported from DRC. For us, when we want to work in the comprehensive control measures, we have to consider like countries free of, countries with outbreak of Ebola, and within the country, areas affected and areas for prevention. We have to think about pillars that including the patient management. Patient care is the first, so early detection cases, and as mentioned also by Mike, the patient becomes infectious when he develops or she develops symptoms. So before the symptom, during the incubation period, before developing the symptoms, no, it is not possible to be infectious and transmit the disease to other person. So the first, patient management. Second, surveillance, laboratory and ring vaccination. And as mentioned comprehensively by Dr. Mike, this vaccination, it is now one of the key elements in controlling Ebola. Maybe for the future, we will find vaccines for all the strains of Ebola. Logistics, the supplies is one of the pillars that we have to focus. The media, we are saying risk communication and community engagement. And for the West Africa, because of the denial of the communities and the hidden of the patient, and also they want to bury them by themselves without any interruption or intervene from the health cadre. This all affect the intervention at that time and prolong the duration of the disease itself. Behavior and social intervention, psychosocial support, these are part, and control of the reservoir in nature. With all of these, overall coordination during this outbreak. Briefly, the plan here in Sudan, we prepare ourselves for the when Uganda and DRC reported. We prepare ourselves here for expecting cases to be arrive in the country, and we found that we have 3 areas cross borders. One of it is Yoda through South Sudan from Uganda. Some returnees used to come through South Sudan. In addition to the Port Sudan and Khartoum international airports, from them we used to have regular travel flights from Uganda to Sudan. As you know that we have refugees there in Uganda, and even in camps. In some of them, they are settled in camps, refugee camps. The others, they are within the community in Uganda. And we have experience of 2025 that we used to follow those who are coming from Uganda during the reported outbreak. I will go briefly in the pillars of surveillance for the preparedness and response in the country. As I mentioned to you, we are expecting the cases to be reported from Uganda because we have direct flights and direct movement of our people from Uganda to Sudan and from Sudan to Uganda. The second thing, we are expecting also cases can be also reported through the RC. And one of the suspected cases that has been reported came from Africa, Central Africa, to Central Darfur and then to Niala, and unfortunately died there with hemorrhagic manifestation. But the good thing, she has no any link with DRC outbreak. طيب, the preparedness package includes activation of Ebola zero reporting cases through surveillance of the health facilities, including also the community-based surveillance, because we know we have porous borders with South Sudan. We are expecting people like what happened in cholera to come not only through the designated point of entry, but also through other ways that can be without paying. Enhancement of event-based surveillance and electronic event intelligence scanning, monitor of travelers. Now we are almost following those who are arriving from Uganda up to 21 days, the incubation period. And this through the various screening and registering them in the points of entry, as I mentioned to you, the 3 points of entry, and then followed by the State Ministry of Health through the surveillance department 21 days. Are working also on the building the capacity of healthcare workers, assigned isolation centers, and as you know, colleagues, you are from the tropical medicine, the one of the assigned area for treatment of the patients when we expect to receive, it will be Omdurman Tropical Medicine Hospital. In addition, also to improve the lab capacity, and now we are working with our colleagues. WHO approved one of the kits to return to come to Sudan. We are waiting for it. In addition, that we are expecting it during these days, and also privately we are working to get it from the market. In addition, we requested also from Africa CDC implementation of comprehensive risk communication, and this has to be also, as I mentioned to you, positive, and including communities, in particularly in the awareness, to raise the awareness among them, to know the disease and to know how to protect themselves and their communities, and also to work positively during the outbreaks. طيب يمكن this part of the objectives I will not go through it all, but improving surveillance, also operation readiness at points of entry and referral isolation reporting mechanism, improve a lab, strengthen rapid response team as a tool, improve the case management and enhance risk communication, psychosocial support, and the others, availability of essential medical supplies and health supplies. The pillars that we are working on it, including all this, from the surveillance, capacity building, the lab, blood bank service, quarantine and entry points, isolation rooms and case management, risk communication, and isolation also including infection prevention and control, risk communication and community engagement, coordination within with the partners through EOC and health cluster, in addition to the bilateral meeting and having also the task force. Viral hemorrhagic task force has been reactivated to focus on the cholera preparedness and response. Also monitor and evaluation of the all these pillars, and considering some of the areas and some of the high-risk population, including the refugees who are returning from the Uganda. We are expecting during this month, many people will arrive from Uganda and return back to their home. In addition, also to activation of the One Health platform, that because this is one of the zoonotic disease and availing the supplies. These are part of what have been implemented, and I will share it with you. It is in Arabic. Maybe those who are not Arabic speaker or cannot go through it, but it is just activities that has been implemented and existing now in in Sudan for the preparedness of Ebola in the country. This is in general what I want to say. Again, I want to address that disease has no border, and Sudan is within the high risk because we are bordering South Sudan. No any report till now from South Sudan, but the risk is high because South Sudan is bordering the affected counties in DRC. So the possibility of having the disease is existing, and the possibility also of transmitting the disease and distributing the disease from the neighboring countries like Uganda and South Sudan is existing. This is from my side. Over to you, Zilal and colleagues. Thank you.
Thank you so much, Dr. Muntasir, for sharing Sudan National Plan to respond for the expected Ebola virus outbreak in the country. Allow me to welcome Dr. Amal Haj Elnoor Soar Al-Dahab. She's a public health specialist, certified professional in healthcare quality, certified professional in patient safety and infection prevention and control, and proudly she served as a former Director General of the Tropical Diseases Hospital. Dr. Amal will be sharing with us an inspiring leader and one of our former colleagues in the hospital. Please, Dr. Amal. And shortly after, we'll take the questions for both speakers. Thank you.
Assalamu alaikum wa rahmatullah. Thank you, Dr. Delal, for the introduction. أنا متأكدة if my voice clear.
Yes, we can hear you clearly.
Okay. Okay, I'm Dr. Ahmed Hayyanur Suarez Dahab, and today I am deeply privileged to deliver those slides in memory of Dr. Abdin Khairi Abu Shanab. He did not know the name of the deceased at that time, but he only knew the name of his profession, a doctor. So Dr. Abdin Khairi was born in 1948 in Kuked Mahas, near Delgo in northern province. He spent his elementary and intermediate schooling in northern province. Secondary school was at Port Sudan, and his medical education was at Faculty of Medicine, University of Khartoum. He spent his internship, housemanship at Khartoum Teaching Hospital, and served as a medical officer in Umdurman Teaching Hospital and a medical officer in Maridi Hospital. In the second half of 1976, a deadly unknown epidemic appeared in Maridi, South Sudan, formerly Equatoria. The symptoms were fever, headache, bleeding from multiple sides. The devastating toll was that half of the nursing staff at Maridi Hospital died at that time. And Dr. Abdin was performing his hardship area duty in Maridi Hospital at that time. And despite the mountain deaths among staff, he continued to work to see his patients, and eventually he contracted the disease himself. Alarming numbers of staff who fell ill, 41 died, medical staff panicked, and many refused to return except a few brave ones, some of whom died eventually. Dr. Abdurrahman Ali, the medical officer at Rio District Hospital, was serving as a medical officer in Liwi, which was near Meridi, miles from Meridi. The military commander informed him that Dr. Abdin was critically ill, and Dr. Abdurrahman escorted him by military vehicle first to Liwi and then to Juba at the next day. Dr. Abdin was left at that time in the doctor's rest house so as to be cared for until a decision be made. In Juba, meantime, Dr. Abdurrahman met with Dr. Justin Yak, the regional minister of health, and Dr. Yak gave them 5 return tickets to Khartoum so that an investigation team could come back to Juba, physicians, microbiologists, or virologists, to dig for this epidemic. They decided not to bring Dr. Abdin to Khartoum immediately, risking further spread of the disease. But in the same day after arriving in Khartoum, Dr. Abdurrahman met with Dr. Abbas Mukhtar, the Undersecretary of the Ministry of Health, and they tried to contact different physicians in the field of tropical medicine in Khartoum, but failed because unfortunately it was the Eid al-Fitr holidays at that time. So they decided to go to Dr. Abdul Ghaffar Abdul Rahim, Director General of Tropical Diseases Teaching Hospital at that time. He served from 1976 to 1986 in his house. Dr. Abdul Ghaffar Abdul Rahim decided to fly the next day to Juba, accompanied by Dr. Abdul Rahman, and immediately went to see Dr. Abdin and found him extremely ill. After a long discussion with Dr. Yak, Dr. Abdul Ghaffar convinced him that Abdin Khairi was moribund and it's better for him to spend his last days beside his family. So accepting to take full responsibility, Dr. Abdul Ghaffar flew back to Khartoum with Dr. Abdin Khairi, and Dr. Abdul Rahim went back to his station in Delhi. In Khartoum, Dr. Abdin was admitted to the casualty ward in Khartoum Teaching Hospital, feverish patient, bleeding, and eventually in a coma. And despite extensive investigations, no definite diagnosis was reached at that time. And after days of suffering, he died. His nephew described his slow decline from being unconscious to cirrhosis to bleeding from every side until he passed away. So, although Dr. Abdin's life was cut short, his legacy endures. For more than 20 years, a ward at the Tropical Disease Teaching Hospital proudly bears his name, a lasting tribute to a physician who remained at his post when his patients needed him most. Decades after his death, Dr. Abdin continues to welcome patients and inspire physicians. His name lives on through the ward dedicated in his honor at our tropical hospital in Omdurman, Khartoum, in Sudan. And these are pictures of the war. May his memory continue to inspire generations of physicians. Thank you very much.
Thank you so
Okay.
much. Thank you so much, Dr. Amal. And may his soul rest in peace. ربنا يرحمه ويغفر له في عال الجنان يا رب. His bravery, and he will remain young forever, young and brave. Thank you so much. This is very inspiring, and it's well known for the Sudanese doctors to be in the front line despite all the challenges we could possibly face, from infection outbreaks to the pandemic to the wars and unrest in the country. This is very inspiring. Thank you. Okay, we'll go to questions. I believe there's a question in the chat box. Okay, one of the doctors has been recently assigned to a job. He would like to know the most trusted technique and which type of testing should be suitable for Ebola outbreak in Sudan. Dr. Kidd?
Would you like me to answer that?
Yes, please.
So I think the early detection of virus by some kind of amplification technology, PCR, or there's a number of other different amplification assays that can be used. That's the most, in my view, that's the most sensible test. There probably are some serology assays which would be useful for epidemiology use, but for diagnosis of somebody who's acutely unwell, I think it would need to be viral PCR. It's not to say that sounds like an easy answer, but obviously there's a huge amount of safety that has to be put in place around the handling of blood and samples from individuals that might be infected with Ebola virus. So, but that's not unachievable. And I think it was, again, a lot of lessons were learned in the West African outbreak. Laboratories were set up and very strict protocols applied to make sure that everybody in the laboratory was working as safely as they could. But direct answer to your question is some form of PCR.
Yep, RT-PCR it is. And a comment from Dr. Mohammed Jibril. The intensive community work seems to be burdening. He would like to take a chance and say that building a competent medical sector individuals, it starts with the connection between lab science. Dr. Muntasir, can you comment on that? In order to have a strong health system, it needs to be between the medical doctors and the lab scientist.
Thank you very much. In continuation to what has been mentioned by my colleague, Dr. Mike, for us in Sudan, for this period, up to having the reagents for the PCR. We will collect the sample, and it has to be also with the precaution measures, and we will send it through the IATA rules to South Sudan for us now. South Sudan as a reference referral pathway as one of the reference lab for the Ebola, in addition to the WHO, other WHO reference labs. But for nowadays, we will work like that. I think the committed and confident doctor, a medical doctor who's lab scientist, definitely with building the capacity during the university time, during the graduation, before the graduation. This is one of the areas that we have to work to increase the awareness of our future medical staff and other supportive staff. I think this one of the areas that has to be bridged in all our institutes here in the country, raising the awareness. In addition to that, also the responsibility of the Ministry of Health to share the protocols and also to share the guidelines for the treatment, for the surveillance, for the appropriate infection prevention and control measures. This is also one of the references for the medical cadre, in addition to what has been shared also by Dr. Mike through the websites, the technical websites like WHO website, CDC websites, and other institutes, reference institute web sites. Over to you, Dr. Azra.
Thank you so much. That's great. I believe there's two more questions answered by Dr. Kidd. Just for the record, question is, what is the mechanism by which Ebola virus induced lymphocyte apoptosis? And does inhibition of lymphocyte apoptosis improve disease outcome? And the answer for that, would you like to answer yourself, or go ahead and read your answer?
Thank you. Let me just find it. I'll scroll up a bit. Yeah, what's the mechanism by which Ebola virus induces lymphocyte apoptosis? And does inhibition of lymphocyte apoptosis improve the disease outcome? So I just briefly replied to say there's a number of mechanisms, more than two, I think. But the viral glycoprotein, so it's a protein that's on the outside of the virus, which, if it contacts cells, it can be released as like free protein in the blood, and if that contacts a lymphocyte, it can ingest the protein, and that protein itself can induce apoptosis. It doesn't need the whole virus to do that. It's a very puzzling. It seems to affect the toll-like receptors, some of the very basic protection mechanisms of a cell, and causes it to release some cytokines that affect apoptosis. It's not something that I could easily answer, but that was the most obvious thing that I could think to put.
Thank you. And another question about, is the virus detectable during incubation period? The answer for that is RT-PCR, as mentioned by yourself. Allow me to welcome Dr. Rasha Umar. She's an infectious disease physician in South Yorkshire, UK. She's also specialized in GUM and HIV medicine, and we had the honor for her to be presenting in our HIV sessions. Dr. Omar. If you have any comments or highlights, please feel free to unmute yourself.
Hello, Assalamu alaikum. Can you hear me?
Yes, lovely to hear your voice again.
Yeah, thank you. Thanks. It's a lovely session. So it's very informative for me. So I'm primarily a GUM consultant, sexually transmitted in HIV, and then specialize in infectious diseases the other way around. So this is very informative for me here. Thank you, both speakers. I have a question, actually. You mentioned because of my interest in sexual health. You mentioned there is a reserve, and this is for both speakers, if anyone can answer me. There is a reservoir in semen. Is there a risk of sexual transmission and also vertical transmission? And has there been any reported congenital transmissions of Ebola? I know they die actually, but people who survive and they have semen, Ebola virus in their semen, is that a route of transmission?
Could I answer that?
Yes, please.
Salam alaikum, Russia. Nice to hear from you.
Assalamu alaikum, Mike. Thank you so much. I missed that part of your lecture, but it's thank you for this is a very fantastic platform, and I really applaud all the organizers for doing this. It's a privilege.
It's been a very interesting afternoon. Thank you. In answer to your question, yes, it can be infectious virus in semen and can transmit to sexual partners. It's one of the ways of what they call cryptic transmission, can occur in a country where there's no obvious circulation of Ebola virus, either because it's asymptomatic animals, or suddenly outbreaks can start, and it could easily be because of a sexual transmission event, and nobody would be suspecting that it would be Ebola that was the method by which it was acquired. I think that it's been proven in the West African outbreak that several small outbreaks started this way. So it's a significant problem. Yeah, I don't think everybody who's a survivor has infectious virus in semen, but I can't remember what the proportion was, or even whether it's estimatable. But in principle, it happens. Yeah.
That's great, thank you. And Dr. Zainab Abdullah is asking, based on the previous Ebola outbreaks, what are the key lessons for enhancing epidemiological surveillance and ensuring early case detection within primary healthcare system? Good question. If a patient presented to a primary healthcare center, GP practice.
Yeah.
Can I start and then Mike can continue if you...
Yes, please.
Yeah,
yes, please.
Definitely suspect if you know it, you will expect it definitely. Like the clinical features that we are observing in some of the diseases. So the same for Ebola. I will give you example like diarrheal disease. If you are not expecting cholera, you will not diagnose it as a cholera. And has been observed in many countries that has no recent histories of outbreak of cholera. Like in Lebanon, like in Syria, during the recent years. For us here also, if we do not increase the awareness among the health cadre, generally the health cadre, including the medical cadre, we will not detect early the outbreak. Although Uganda has recent experience of Ebola. Again, health cadre, health cadres, not one health cadre, health cadres reported infected by the virus. So increasing the awareness among the health cadre, this is one of the tools to reduce the burden of the disease, the transmission, and also improve the early detection of the disease through the regular systems. This is one of the areas, the key areas that we have to work on it before the outbreaks, because during the outbreaks, there will be panicking in the first days and then confidence in the last days. So we have to work before the outbreaks in improving the capacity of the cadres, health cadre in general, in detection through distribution of case definition, clinical features, and operational case definition, and treatment for infection prevention and control measures. This is from my side. Over to you.
Thank you. Dr. Kidd.
Thank you, Dr. Muntasir. Thank you very much. I think that you started off very well, but and again with your start about the case definitions, and highlighting the overlap that they might be with other different infections and diseases that could present. Yeah, I think the case definition. I remember even with MERS, that was an important feature. And of course, you can only get that information after you have a certain number of cases with the right with the correct diagnosis. I mean, let's use an example of malaria. You know, you can diagnose malaria, but if you're not able to diagnose Ebola virus infection, then it may be that in the early days you consider patients with compatible symptoms that are not malaria to be possible Ebola virus cases, but that depends on the prevalence, the incidence, sorry, how many cases you've got. If it's your first one, that's very difficult to pick up. But I agree with you that case definitions are key.
Yeah, particularly it can be very similar to dengue, hemorrhagic fever, which is highly prevalent in the country as well. Another
Yes.
question, is there active cases now and how many? 0, fortunately. Okay. And we'd like to keep it that way. Question for Dr. Muntasir. Is there any surveillance mechanism, includes any integration with the regional centers or platforms like Africa CDC or other, which may facilitate and accelerate information exchange? I think it was previously answered, but over to you, Dr. Muntasir.
Thank you very much, President. Also, who asked this question. I just arrived from one of the meetings with considering the Ebola virus disease in the Africa CDC Eastern region. I arrived just from Mombasa, and we were in a meeting discussing the issues of the cross-border sharing of information, and also the current situation of the outbreak in Uganda, because Uganda is part of this the eastern region. And what is the lesson that we can learn from the current outbreak, and also the modality for sharing the information? Definitely, there are technical areas for sharing the reports, including Africa CDC and WHO sites, in addition to the bilateral and meetings within the region and also within the continent regarding this Ebola. And what happened during the declaration of as a continental public health emergency of continental concern from Africa CDC and also public health emergency of international concern by WHO. There was serial meetings for the ministerial, for the technical staff, and even for the presidential Africa in the African presidents in the African continent, and there was commitment between all that to contain the outbreak, and there was also a contribution from the donors and also from some of the countries, including South Africa, for the containment of outbreak within Africa. These are some of the activities that showed solidarity among the countries within the continent and also globally through the donors, through also the countries, developed countries, that they are supporting the prevention part, preparedness part, and the response part within the countries. Over to you.
Thank you so much, Dr. Muntasir Elnoor, and would like to truly and heartfully thank you for all the efforts controlling the different outbreaks in the recent few years, starting from the pandemic, and we recently celebrated 0 cases of cholera. We know it can be very challenging with the internal displaced persons, but it was managed successfully, as well as malaria and dengue fever. The numbers are dramatically decreasing. So thanks for all your heroic work. Question from Dr. Dalal Al-Amin. Is there any RCTs, randomized controlled trials, about doxycycline or ivermectin, if their effect by reducing cytokine storm, like those done in dengue and COVID-19? Over to you, Dr. Kidd.
Thank you. Yes, sorry, I did type a brief response in the chat box. I've not seen any trials of those of those particular drugs. I don't think they have a very good press after some of the recommendations that were made, particularly in the US, I think. But it's an interesting concept of, you know, how would we treat a cytokine storm in a patient who didn't have Ebola? I just did wonder whether it could be interesting to regard it as a form of septic shock and see if there's a different approach could be used to try and control that, as well as the direct acting antivirals like remdesivir. You know, a kind of a combination therapy approach, but I haven't seen any trials of that either. I think it's an area that's open to some debate, I would guess.
Yeah, absolutely. And we basically learn by doing when it's related to areas where there's little known. Right. Another comment from Dr. Amani Alamin. She's sharing previous experience working during the dengue fever outbreak in East Sudan. And she said that what they were doing basically to isolate suspected cases in their own homes and keeping close contact with them. She says this was the only available method because it was active war zone at the time. They didn't have the facilities. And of course, she shared also the competency of the teams and community participants. Thank you so much, Amani. Right. Dr. Muntasir, a question for you. How many number of cases needed to consider an outbreak in the country? And can the disease transmitted between patients sweat as part of the body fluids?
You know, during the infectious secretion and secretion will transmit, unfortunately, the disease. For us, disease like if it is not endemic, one confirmed case, this means an outbreak, and this is for Ebola. For other diseases like the endemic diseases, this will be different by having alert threshold and epidemic threshold for the including the numbers of the cases. So in this event, Ebola virus disease, one confirmed case is an outbreak in the country. Over to you.
Thank you. And a question from myself. Is there any efforts for vaccination development? And we know the healthcare professionals and the first responders would be the targeted population to be vaccinated. Any efforts on vaccinations?
Would you like me to
Yes, please.
answer just from my side? Yes, there's some, as I mentioned in my talk, there are a couple of vaccine candidates that are being developed at the moment, and have been assessed by the WHO Technical Advisory Group for likely deployment in the right form of clinical trial. I'm not sure that a randomized clinical trial is ethical, so you have to design the trials differently, but still be able to get valuable information out at the other end, just as you would for an antiviral drug. But I would think that the healthcare workers would be a good way to do that to start with, and then also for the if the vaccines show promise, it could be used in ring fencing exposed individuals around around the case. So if a family member is diagnosed with Ebola disease or passes away from Ebola, then the family could be vaccinated. It's a bit difficult because I think that the vaccines take about 2 weeks to become effective, and so the ring fencing has to be a little bit wider than probably the closest exposed members of the family. But I think those two areas, healthcare workers and to try and reduce the spread throughout communities in ring fencing, would be the most useful.
That's brilliant. Thank you so much. I think we came to an end for today's session. Thank you, our respected speakers, for sharing your experience with us today. Any final words, Dr. Mike Kidd?
No, except I sincerely hope you don't get any cases.
We try to keep it that way. Thank you so much.
I'm sure you've got all the intellectual capacity and to get that sorted. I sincerely hope that you can manage to do that. And many thanks for asking me to speak and to be introduced to fellow Sudanese, if I can say.
Thank you so much.
And thank you, Dr. Muntasir. Thank you.
You're an honorable member of the Sudanese community by proxy. You're more than welcome. And we're looking forward to more collaboration with you. We deliver regular sessions every second week about different infectious diseases. It was a pleasure to have you with us today. Thank you.
Thank you for the invitation.
Thank you. Dr. Muntasir, any final words?
Thank you very much, Dr. Zilal, for organizing this and all tropical medicine diseases colleagues for organizing this webinar, and thanks also to my colleague Mike for giving us this fruitful information regarding the disease. And we wish that we can do our best to affairs protect the country from entering the disease, or if entered, to early detect the disease and contain it with comprehensive measures. We are doing our best. In addition that, I want also to inform you, as mentioned by Dr. Amal Abdel Khairi, Allah yarhamu, we have also colleagues from the Federal Ministry of Health who joined the investigation and returned back. One of them is Prof. Ali Idris Baneb, and also public health specialist Stazna Abdel Gadir. These are part of those who were with the people who investigate the disease and return back safely. and الله يرحمه دكتور عابدين. يعني الحاجات اللي بتتحكي انه اول ما فتح اول بيشن البلد يعني انتشر في كل غرفة العملية unfortunately، ودي اللي خلت الديسيز ينتشر بصورة كبيرة among the health workers في الوقت داك في مريدي. شاكر ومقدر لكم كلكم، وآمل إنه الناس تكون استفادوا وكنا خفيفين عليهم. شكرا جزيلا مرة ثانية. تفضل يا فضل.
Thank you so much, Dr. Muntasir, and we do appreciate all the efforts and great job you're doing. And you're not alone. We're behind you. We try to spread the word, continue the ongoing medical education for all the doctors in Sudan and outside as well. And this is our message. We try to basically spread the knowledge about infectious diseases, which is a huge burden in our country. I was so happy to moderate today's session. We've learned much more about Ebola virus, and I think we're prepared and would like to keep it 0 cases. Thank you again. Today's discussion highlighted the Ebola virus disease. It remains a serious public health threat, requiring rapid detection, timely reporting, effective infection prevention and control, and a strong community engagement. Successful outbreak response depends on collaboration between all of us. It's not just the Federal Ministry of Health, involving all the healthcare workers, the public health authorities, the government, and most importantly, the communities. By strengthening surveillance system, ensuring a safe patient care, promoting accurate public education, and supporting research and preparedness, we can together reduce the impact of the future outbreak. Thank you all. Thank you to our speakers, all the participants, for your contribution, for your commitment to improve global health security. And accept our kind regards from the Tropical Disease Hospital Academic Club. On behalf of Dr. Amal Ahmed Haj Elnoor, Dr. Rayana Ali Tunja, Dr. Sarah Tayyib, Dr. Taqwa Saeed, Dr. Lu'ay Amar Rayah, Dr. Zainab Abdullah, and myself, Dr. Zalal Sharif. It was lovely to have you with us. Have a lovely evening, and we'll see you in our next session. That will be visceral leishmaniasis every second Saturday. We look forward to see you in the near future. Thank you and have a lovely evening. Bye.
السلام عليكم. شكرا جزيلا.